Hi, and welcome everyone. My name is Waqas Haque. I'm a Hemong Fellow, University of Chicago. I joined one of our special guests today, Mary Pasquinelli, who's at UIC. Thanks so much for joining us today, Mary.
Yes, I'm happy to be here.
Yeah, and you're doing a lot of great work at the boundaries and intersections of lung cancer and screening. Just a brief intro about yourself and what you do.
Yes, so I'm a nurse practitioner. I have a doctorate in nursing practice. I've been in the field of oncology for 40 years now. And what I do at UI Health for about the last 10 years, I am now the director of the lung screening program. I helped develop the program. I also have an incidental pulmonary nodule clinic and a lung cancer clinic. So I see patients throughout the care continuum from lung screening to diagnosis and treatment.
Yeah, no, so thanks for that introduction. And of course, where we are now, obviously a lot's changed in terms of what we understand about determinants of lung cancer and also screening programs. Just really quickly, what kind of motivates you to be in this area and kind of to push the boundaries of this field?
Yeah, so as I was saying, I started in nursing 40 years ago,
Mhm,
and I've always been in oncology nursing. It's
mhm,
a passion of mine. I actually went to nursing school to become an oncology
mhm,
nurse. And when I was hired at UI Health 10 years ago, I was hired in pulmonary and thoracic oncology. And it was the same month that CMS came out with their recommendations for lung screening. And
mhm,
so I had the opportunity to kind of be at the very beginning of a whole new program and possibly even kind of a paradigm shift because we know lung cancer is the leading cause of cancer death in the United States and actually globally. And most of our patients, by the time that they have a symptom or diagnosed at stage 4, and with screening, we know from screening like breast screening, breast cancer screening, we're able to catch lung diagnosis of breast cancer early. We were hoping to do that with lung cancer. And over the last 10 years of looking at all of our data, we have been able to significantly shift the stage. So we went from 60% stage 4 lung cancer diagnosis at UI Health down to 40% stage 4. But within our lung screening program, the majority of patients are diagnosed at stage 1. So the stage shift went from, 60%
right.
uh, diagnosis of lung cancer at
Mhm.
stage 4 to 40%. And our lung
Wow.
cancers at stage 1 went from 20% to 40%. So it's really great.
Wow, that's amazing. Yeah, I'm sure a lot more patients who are now candidates for definitive radiation, chemotherapy, surgery. So that's really exciting to hear. I want to kind of go back to some of the screening work you've been doing. I know you did some work presented about AI and kind of helping with detecting lung cancer. So can you just describe the study a little bit and kind of its performance in the validation study?
Yeah, so I've
Mhm,
done a lot of work around health disparities in lung
mhm,
cancer and quite a few publications on risk prediction models using the
mhm,
PLCO risk prediction model. And then Sybil
mhm,
came out 2 years ago. It was announced or presented at World Lung and 2 years ago in Singapore. And
mhm,
I thought this was a game changer, but it was also
mhm,
the training set for Sybil, which was developed
mhm,
by MIT and Mass General Hospital, was
mhm,
trained on the National Lung Screening Trial, which was
mhm,
91 or 92% white
mhm,
individuals and only 4.5% African Americans. And the population that I serve at UI Health is about 75% minority. And we
mhm,
know that African Americans have the highest incidence and mortality from lung cancer, even
mhm,
though they smoke cigarettes less. So I wanted to be
mhm,
sure that AI models need to work for all populations. And so I talked to Dr. Alicia Sequist, who helped develop Sybil at this conference.
mhm,
And she asked me to join a Sybil consortium with MIT, Mass General, us at
mhm,
UI Health, at University of Illinois, Chicago Baptist, and
mhm,
Wellstar. And then
mhm,
we did a validation study at our hospital. And
mhm,
so we found that Sybil works very well in our population. It's a diverse minority population, and our AUC year 1 was 0.94, and it goes out
mhm,
to 6 years of a prediction,
mhm.
and that AUC at 6 years was 0.79. So it's working very, very well.
Yeah, and how long were the patients followed up for in the study?
This was over 10 years. It was
10
just
years. Okay.
the
Okay.
baseline study. It was over
Okay.
2,000 individuals. And they had scans from 10 years ago to more
Right.
recently.
Yeah.
And, but it's a 10-year kind of follow up of our 10 years um, of scans of over 2,000 individuals. We also separated out just the whole cohort versus
Mhm.
the African American cohort, and the
Mhm.
AUC curves were almost identical.
Well,
And when we compare our AUC curves compared to some of the other validated studies, we have it
mhm.
validated through the National Lung Screening Trial, which was the training set, Mass General, which is also screen eligible, over 90%
Mhm.
white individuals. We have two from East Asia. We have one from Taiwan and
Mhm.
one from South Korea. And all of our AUCs at 1 year, 0.86 was the lowest to 0.95, which was the highest in the
Mhm.
Taiwan population. So it's working well in
Mhm.
different populations. The East Asian population is very interesting because
Yeah.
it
Oh,
also includes individuals that don't smoke cigarettes.
right. Yeah.
So, and it worked very well in that population too.
Wow. So really telling us that it may not necessarily be like a disease biology problem in terms of explaining the differences, but rather, getting people access to care at the right manner to help sort of, address these disparities that we see for different, populations, minority groups. So really, they're really important stuff. Just to go back, you mentioned AUC or area under the
Mhm.
curve. Just for those who might not be familiar with the metric, can you just, briefly explain what that means and why it's considered good for a predictive model like Sybil in this context?
Yeah, so an AUC of 1
Mhm.
means that the model distinguishes 100% perfect ability to distinguish a
Mhm.
high risk case from a low risk case. An AUC of 50 is like flip chance.
Right.
So when you have an AUC above like zero point 0.8 is considered strong, and then an AUC we were above zero point 0.9, so that was excellent. So our
Mhm.
curves were of Sybil was, we would say, excellent discrimination at year 1 and a very good predictive value at year 6 with the AUC of 0.79. So an AUC of 1
Mhm.
would be perfect ability to discriminate high versus low cases.
Oh, no. Yeah, very nice. And
Mhm.
in addition, I know this study focused on low dose CT scans, but of course, we're seeing a lot of alternative tests that may be able to detect possible suspicion for lung cancer. Of course, now we have like circulating tumor DNA or liquid biopsies that are being able to measure tumor load in the bloodstream, and that's being used, especially in patients with lung cancer for disease monitoring. Curious to see if you envision those, liquid biopsies or even like X-rays when people are admitted in the hospital, if these could potentially fit into the screening workflow and maybe in combination with low dose CT.
Yeah, a lot of people are looking at blood-based biomarkers, and it's
Mhm.
a really interesting field.
Yeah.
And I hope that in the future this will all kind of
Mhm.
be combined with, it could be a blood-based biomarker that would help,
Mhm.
or it could be like an AI-generated assistance. The cool thing about Sybil is
Right.
that you don't have to tell the model anything, no age, or if the patient has a smoking history or
Mhm.
anything. So it doesn't need any information or any
Mhm.
demographics about the patient. It just runs
Mhm.
it and tells you, predicts if it predicts the future risk of lung cancer. In the
Mhm.
blood-based biomarkers, and ctDNA has done really well. We're using
Mhm.
ctDNA a lot after a patient is diagnosed with cancer,
Right. Yeah.
after when we're doing surveillance to see if maybe the cancer is coming
Mhm.
back, and we can actually see a rise in ctDNA
Mhm.
even before sometimes the changes are on the CT,
Mhm.
seen on the CT
Right.
radiographically. So there's a lot of great potential here. We're also kind of thinking about, could AI be used better in like even
Mhm.
chest X-rays in the future? And I think that is
Right. Yeah.
a field that would be great because a lot of the countries, it's a global burden. Is Lung
Right.
cancer has a
Yeah.
global burden of disease, and if we're looking at lower income or middle income countries that may not have access to chest CTs, many
Mhm.
of them do have access to chest X-rays. So maybe in the
Mhm.
future we can look at models using a chest X-ray.
Mhm.
There was a long time ago with the National Lung Screening Trial, it said that chest X-rays aren't as good as low dose CTs, but
Right.
technology has changed and radiology
Yeah.
has changed. So maybe in the future that will hold some promise.
Right, for sure. And kind of going beyond that and talking about some of the different disease, populations you mentioned, of course, we have a higher, risk groups, lower risk groups, right? So with the lung cancer screening guidelines, of course, in the last few years, is a little bit less restrictive in terms of, pack years and age for screening. But I'm curious now that we have AI to maybe be able to stratify patients who are higher risk and lower risk, like based on family history or like if they have COPD, even if they're a non-smoker. Like how do you think that these tools could be improved for screening in the higher risk populations?
Yeah.
Yeah.
So the PLCO risk prediction model actually has like 11 variables in there, and that has actually been shown to be really decrease any disparities between men
Mhm.
and women and between different races.
Mhm.
And I think that, we know that like a COPD increases your risk for lung cancer by
Right.
2 to 4 times. And
Wow.
actually, a person that doesn't even smoke at all, but has maybe two family members with lung cancer
Mhm.
almost is at the same risk as somebody who has a heavy smoking history. So we're hoping in the future, I mean, Sybil doesn't use, you don't have to tell Sybil, anything about the a family history or
Right.
smoking history, but there are a lot of models that can take a look at putting risk stratifying patients by
Mhm.
different types of risks. But we know that lung cancer is a very complex interaction between
Mhm.
genetics, biology,
Right.
environment, social determinants of health. And sometimes we don't know exactly what is causing lung cancer, particularly, we know that air pollution can increase a person's risk of lung cancer, and radon and secondhand smoke. How
Right.
do you quantify that? It's
Yeah.
hard to do that. So looking at some of these risk models that don't need, to know what the exposure is
Mhm.
could be very useful in the future.
Yeah. And now kind of jumping gears towards some of the work you're doing with UISQ, the lung cancer screening program. And you mentioned some of those great metrics about less patients being diagnosed in metastatic stage and a lot more patients being diagnosed in stage one, where, of course, there's more, role for definitive cure, potentially. This is obviously without the help of AI. So what kind of process care or sort of quality improvements are you all doing to get those numbers?
So this is a great question, because I
Mhm.
was just at a conference and they were talking about
Uh-huh.
how low, the numbers are, the screening numbers are, and
Yeah.
the adherence numbers are really
Mhm.
low. And a lot of that has to do with the public not knowing about lung screening, and
Mhm.
also engaging our primary care doctors. And at UI Health, we have gone through every single um, kind of data point, from a
Right.
patient, from the community, to the patient meeting with the primary care
Mhm.
doctor, and the order going in, and then the patient
Mhm.
getting screened, to really try to look at where there is barriers and where there are
Mhm.
opportunities. And we've really optimized our screening program. And so at UI Health, our lung screening program used to only have a 40% adherence rate, and now we're
Mhm.
over 85%,
Wow.
because we're able to optimize the program.
Mhm.
So we now do proactive scheduling. So wherever the order is placed within UI Health, we actually
Mhm.
have one of our screening coordinators who knows the guidelines very, very well, and
Mhm.
is able to get that patient scheduled. And we changed how the order is protocolized. So now we can place the order for the primary care doctor.
Mhm.
So there's a lot of different ways that you can develop your program to
Right.
be sure that patients are coming in, and then
Mhm.
patients stay within the program.
Yeah, very amazing. And I'm sure that you're enthusiastic about taking this work at UI Health and kind of expanding it across the country and across the world. And I saw that you were
Yeah.
recently appointed as a board member of the IASLC, the International Lung
Yeah.
Cancer Group. So kind of curious, like, what do you see as a significant, global priority for advancing lung cancer detection, especially in the developing countries where we're seeing more industrialization, more smoking, and where we're going to see a higher uptick in lung cancer in future years?
Yeah, so I am very honored to have been elected to
Mhm.
the ISLAC board of directors. Each year they have a nurse or a healthcare allied person on the board. So I'm very honored to be a part of this
Mhm.
organization. And there's three main pillars of ISLAC, and that is
Mhm.
collaborative science, global education, and promoting accessible multidisciplinary care. So we're really working within those fields.
Yeah.
No matter what we're doing, there was over 100 abstracts submitted to World Lung this last year
Wow.
around lung cancer screening. So, and when I started 10 years ago,
Yeah.
I had a poster there, and it was hard for me to even find another poster on lung cancer screening. And so in 10 years, we have made, amazing progress in the field.
Yeah.
But with that, we are working with other countries.
Mhm.
Some countries are rolling out lung screening very well, and other
Right.
countries aren't.
Right.
So we're kind of looking at those barriers. There's different guidelines for different countries, like the UK and
Mhm.
Canada uses a risk prediction PLCO risk prediction model. United States use USPSTF. USPSTF
Mhm.
can be it can be limiting, and
Mhm.
because it's only 20 pack years, and a lot of people don't meet that 20 pack years. In fact, 50% of individuals who get lung cancer would not have met
Mhm.
USPSTF screening
Wow.
guidelines.
Mm.
And so we're kind of working globally also to understand the risk of lung cancer and understand how we can optimize lung cancer screening. We are also working in the low and middle income countries, and this is
Mm.
where and sometimes your approach has to be different because different countries have different resources.
Right.
And so we're working with these organizations to try to improve lung cancer screening and lung cancer screening at an early stage. I know in Kenya it was very interesting. I was
Mhm.
talking to somebody who's very involved with ISLAC who's in
Yeah.
Kenya, and they were saying that they didn't have a lot of lung cancer, but they had a lot of TB. But then
Mm.
after they started screening their TB patients for lung cancer, was actually
Yeah.
they were being misdiagnosed. They were being diagnosed with TB and not
Wow.
lung cancer. So really being
Wow.
able to work with them and then sharing that knowledge from to other communities was very important. But I think
Wow.
working side by side with our collaborating partners in different
Mhm.
countries is going to be very, very important.
Oh, definitely. No, yeah, I completely agree with all that. And now you have this wealth of experience at UI Health and now with this like so one final question. If you had like unlimited resources, limited money, no restrictions, what's one moonshot idea you would have to detect cancer earlier or prevent it earlier?
Wow, that's a
Yeah.
great question. I don't know what the future is going to hold, but I
Mhm.
really want to have a solution where all individuals can get lung cancer screening.
Mhm.
And I don't know what that looks like yet. We know that
Yeah.
20% of people who never smoked are getting lung cancer.
Right.
And lung
Right.
cancer in those that have never smoked is the fifth leading cause of cancer death. So we
Mhm.
need to do better. Maybe it's going to
Mhm.
be AI. Maybe it's going to be more blood based biomarkers. Maybe it has to be a combination depending on what country you're in with the resources that you have. But I'm hoping that we can find a solution that we have screening for all individuals.
Mhm.
I also think that there's a lot of stigma around lung cancer. That if
Right.
we have it like more of a population health,
Mm.
and that everybody should have access to a lung check like they do have in other countries,
Right.
that this may decrease the disparity, not the disparities, but decrease the stigma, and
Yeah.
more people would get screened if it's kind of part of a preventative health of just getting a lung check or a lung screen for
Yeah.
everybody. You have to weigh the balances of risks and harms, and you want to be
Mm.
able to have this cost efficiently too. But I hope in the future that we can come up with a solution that all people can get a lung check of
Yeah.
somehow, either using AI or using low dose CT, or maybe using some chest X-ray technology
Right.
with AI. Whatever works, I think in
Yeah.
the next year or two, we're going to see an amazing increase in research around this field. So I'm looking forward to it.
Yeah, definitely. Yeah, and thanks for sharing all your insights. It was a really fascinating conversation. And I really appreciate the work that you're all doing with the lung cancer screening and the recent publication and the recent board appointment. So, kudos to you for all the work you're doing, and thanks for joining us again.
Great. Thank you.
Take care.